I suspect that one of our next presenters, Sara Cunningham, is someone that a lot of us know already because of her previous work with the Levodopa pump. What we're hearing about now is how to meet the nutritional needs of a Parkinson's patient, and I know that this is of great interest to a lot of people because I have a brother-in-law in Britain who has Parkinson's disease, and about 90% of the questions that he asks me are on nutrition in relation to Parkinson's disease. Sara works at the Michigan Nutrition Institute. She has a bachelor's degree in dietetics from Michigan State University and her master's in nutrition from Case Western Reserve in Cleveland. As I said, she's worked with the Parkinson's population in the past at AbbVie, representing the Levodopa pump. She's in private practice, and her company is the Michigan Nutrition Institute. Also here is Michael Courtney, another registered dietitian who works with who is a healthcare corporate dietitian, and they are here today to answer questions and give us information on meeting the nutritional needs of Parkinson's patients, and we very much appreciate them coming.
Thank you, Dr. Cullis, and hello, everyone. So I was thinking Mary Sue put me after lunch, and that's probably because as the dietitian, she didn't want me talking about food for an hour before you guys had to eat and salivating out there in the crowd thinking about what lunch was. I'm here to talk about Parkinson's disease and nutritional concerns in the nursing home. I don't have any disclosures at this time. As Dr. Cullis mentioned, I did work for a pharmaceutical company for 5 years. I mentioned that because it helped me really understand this population. So although I wasn't treating them from a nutritional perspective, I got to know the disease state really thoroughly, and I got to see from my nutritional hat, I could see what some of the different concerns were. Today I'm going to talk about, our objectives today, and I hope you can walk away from here understanding how the symptoms and progression of the disease can relate to nutrition. We're going to appreciate the role of Parkinson's medications and how important it is to optimize your medications first before addressing any nutritional issues. But then they also can, especially in the nursing home, give medication administration challenges. And then we're going to talk about the side effects of especially one of these medications. We're going to talk about those nutritional issues, and then I'm going to give you some strategies to take home and talk to your facilities, talk to your dietitians to help improve the nutritional status in persons living with Parkinson's disease. In my experience and in talking to other colleagues and friends and family members that have Parkinson's disease, there are really 5 things that come to mind as very pertinent, reoccurring issues. Unintentional weight loss or malnutrition is top of mind, especially in the nursing home situation where patients are starting to progress further in their disease state. Constipation can run through the whole spectrum of Parkinson's disease, often predating the actual diagnosis of Parkinson's disease. Dysphagia is an under-recognized, and almost 80% of patients living with Parkinson's disease end up developing this. Low protein intake because of the fear of the levodopa and protein interaction, and depression. 50% of patients living with this and may not be seeking out treatment. Before we get started in talking about nutritional concerns, I'm going to do a Parkinson's disease review. So you've had physicians talking, and you've probably been drilled this information all morning long. So I'm going to glaze over it really quickly, but it's important for me to understand that you know what some of these Parkinson's disease issues are, so that when we talk about it from a nutritional perspective, I've at least level set you to a basic knowledge. So Parkinson's disease affects cells in the brain, and these cells are what create dopamine, a chemical. This chemical is responsible for lots of things. It's a mood. So it's your anticipatory hormone. I love cookies. In fact, my nickname with my friends is Cookie Cunningham. So when I'm thinking about my cookies, my brain is flushing dopamine because I'm getting excited thinking about having a cookie. So you can imagine the flip side, if you don't have enough dopamine, you might not be excited about things. Or when you get treatment with a medication that gives you dopamine, you might get too much at a time and have the flip side and overindulge. Dopamine's also responsible for movement. We look at Parkinson's as a movement disorder, and we can't diagnose it until we see it in their movement. It can also affect memory, sleep, and other things. Some of the non-motor symptoms, which can also sometimes be worse than the motor symptoms or affect quality of life for patients living with Parkinson's disease, sometimes worse than their motor symptoms, include depression, constipation, loss of smell, and REM sleep behavior disorder. All of these can affect nutritional status of patients. If you're depressed, you might have a loss of appetite. If you're constipated, well, you know that's uncomfortable. Or I'm home with my daughter now, and I started Michigan Nutrition Institute, if you're wondering what that institute is. If somebody's constipated, it's painful, and a little kid will let you know if their constipation is painful. Adults, they don't scream out quite like a little kid would. Loss of smell. So smell is completely linked to our taste, and if we don't smell anything, we might lose our pleasure in the eating of food. Some of the motor symptoms include tremor. So that's the shaking of the hand or the leg or whatever it might be that's uncontrollable. If somebody is reaching for something, oftentimes they can stop with the tremor, but as the disease progresses, it becomes harder to manage. Rigidity, that stiffness, this is often you don't see it as much, but it can cause a pain in the patients. That stiffness can also go into the throat and make it difficult to swallow things. Bradykinesia, slowness of movement. If somebody is bradykinetic, imagine trying to eat with a fork, how long it might take. At what point do you give up because it's taking so long to get that fork to your mouth, to get the food in your mouth to swallow? And postural instability. So the fear of falling, I might not get up. I might sit in my recliner and rock away if I was afraid I was going to fall all the time. And that can lead to loss of appetite if I'm not moving or exercising. So all of these are very important, and we're going to get in deeper. Levodopa treatment. So right now, there is a treatment. I say it's the levodopa is to Parkinson's disease as insulin is to diabetes. It's often in the beginning prescribed as a pill, and it goes in, gets transported from the stomach up to the brain. When it gets to the brain, it crosses the blood-brain barrier and turns into dopamine, that chemical they're deficient in. Wonderful news. So that's why it's one of the most prescribed treatment and can often be used to challenge or make sure the diagnosis is clear that a patient has Parkinson's disease. If somebody is responsive to levodopa treatment, then it confirms that clinical diagnosis of Parkinson's disease. Carbidopa is often with the levodopa because there are extracellular places in the body, in the stomach, in the gut, that want to pick up that dopamine, pick up that levodopa to convert to dopamine, but the carbidopa protects it so that as much can get to the brain as possible. And levodopa given by itself can cause nausea and vomiting. If you're afraid of having nausea or vomiting, you're not going to take a pill. We really need patients to take their levodopa. So the carbidopa helps protect it, get as much to the brain so that the brain can command that arm to move. We want to get as much levodopa to the brain as possible. These are some of the branded names that levodopa can fall under. Over time, the strength of levodopa might need to be increased or the frequency of duration, so how frequently it's given during the day. So instead of 3 times a day, morning, noon, and night, it might need to shorten the amount of time between intervals because the half-life of it's starting to shorten. It's a 30-minute half-life, and it can last only up to an hour and a half. So that window of frequency of taking it might come to taking it every 2 hours throughout the day. Higher doses of levodopa can cause a side effect called dyskinesia. That's when patients are doing the dance, that's what I say. So they start dancing, and I akin this to Michael J. Fox. If you've ever seen Michael J. Fox on TV, he's doing the dyskinesia dance, not tremor. Patients have a hard time differentiating sometimes between those two things. And patients may not realize that they're in dyskinetic state because it actually feels better to them. They're not rigid, they're actually able to move, although to somebody sitting there with somebody that's dyskinetic, you might feel uncomfortable because they can't control themselves and they're continuously moving. It's involuntary. It's important note to that. So the green is when patients are taking their levodopa, we call it on. When the medication is working, they're on. They're free from their Parkinson's symptoms. When it's not working, we call patients off. It's important to understand on and off because they're going to ride a roller coaster throughout the day. And this roller coaster gets worse as the disease advances. And when they get into the nursing home, they're probably riding a pretty rocky roller coaster over here. you see that the green, that target that we're trying to hit, gets narrower and smaller and smaller. So you're trying to get a really small bullseye. And you might have to give more levodopa, and to actually get a patient on, you're gonna have a dyskinetic state. Almost, sometimes if you don't give enough, then the patient just never turns on. So it's important to understand that they're riding this, and it gets harder to get into that on state. Well, one thing that also makes it even more challenging is there is an interaction between levodopa and protein. Protein is very important as we age, especially in nursing homes. We want our patients to have at least 1.1 gram per kilogram per day. Dietitians know this. I mean, all patients in nursing homes, they're at risk of sarcopenia, they're at risk of muscle wasting, and so we want to retain as much muscle so that they can continue doing activities of daily living, showering, walking, moving, and that muscle wasting, if they don't have muscle to move, they're not able to do these things. In the beginning, when patients start taking levodopa, patients might need to eat food with their levodopa dose. Remember I talked about that nausea and vomiting as the body starts getting used to it, and so we encourage them to eat with their levodopa. And they're not relying completely on the levodopa. The brain is still creating dopamine. As it progresses and patients are losing the neurons, they're losing the capability of creating dopamine, they rely more on that medication. So it's important to try to have that levodopa administered without food. So either 1 hour before or 2 hours after. And I'm gonna spend some time really diving into this because as nurses, CNAs, administration, this is a very key point to maximizing our patients' on time. Let's remind ourselves what protein foods are. So it's dairy, meat, seafood, eggs, quinoa, soy, nuts, protein shakes. So it's prevalent in a lot of foods that we want them to eat. Okay, so let's take a look. We have a time chart across the top, and this is a military time. In a nursing home, standard meals are usually at 8, 12, and 5. So that's pretty given. The dining hall is open at this time. Your nursing home might have slight variation. Just go with me if it's a slightly different time. If it's a QID prescription, and most doctors are going to write QID. They're not going to be time specific, although that could be a best practice. If you're a doctor in private practice and you're seeing a patient in a nursing home, it would be recommended to, instead of writing QID, to write down the specific times you want them taking it, and if you know when their meals are, so you can time them an hour before the meal, even better, because the nurses then can follow what time. Otherwise, nurses have 35 patients they have to administer medications to, and sometimes it's not just an hour. That would be really challenging, and they have to deal with their diabetics who need their medication around meal times, possibly, or their renal patients who need phosphorus binders around meal times, and then they got their Parkinson's patients who might need it an hour before or 2 hours after. So juggling all of these different patients, it's chaotic, crazy, you're trying to get all this done. So there is a window, so usually maybe an hour before, an hour after, or a 4-hour window that you can administer your medications. So let's say the nurse has their medication cart, they go down the hall, this patient, here's a sample patient. Patient was given it at 7 a.m., beginning of MedPass time. That patient, because it was written QID, and we weren't really thinking about meal times, and we weren't thinking about all that, that patient now got it at the end of the second MedPass time for QID. So now this patient, if we go back to that roller coaster chart, green means on, yellow is dyskinetic, and red is off. This patient started the morning, probably a little off, maybe frozen in their bed. They were given their medication. Awesome. They were given an hour before meal. They got to mealtime. They were able to absorb and eat as much as they could. Starts wearing off. Well, they probably needed another medication administration, but they didn't get it. Now this patient needed to get to mealtime, and mealtime was really challenging. They were extremely bradykinetic. They were slowly walking down to the dining hall. They got through maybe 25% of that meal because they were so slow. Then they came back to their room and they got their medication at the end of that. They got their medication. They didn't quite turn all the way on. And then they got it at the beginning of the next meal pass time. So now we have a layering of the 2 levodopas. You give them too much at a time, and you're gonna make them dyskinetic. So now this patient is flying all over the place, can't sit still, going all over. And then they have a poor mealtime because now they're dyskinetic and they can't keep flopping their food around. I'm being extreme. Some patients aren't that extreme. I'm trying to drive home a point of side effects and symptoms of what this medication can do. And then they get it right before bed when often either the patient doesn't need to perform as many activities of daily living before they're going to bed, or sometimes symptoms aren't as severe and don't present themselves when they're sleeping. Okay, let's take in another patient. This patient was prescribed 7-Eleven. They get it at the beginning of the MedPass time, right there, evenly 4 hours apart. In an ideal world, not thinking about the other disease progression side effects, this patient has a better curve. They are easier to shower with because they are on with their medication. They have a better time in rehab or in their exercise class or therapy because they're on and they were given their medication and they're maximizing the absorption. They don't have that interaction with the protein and they're having a better day. And they're making your life easier because they're not competing and they're getting as much of that levodopa that they need into the brain so that that brain can tell their arm, let's get up and move that fork to our mouth. Another solution to this that's been studied, and there's small studies, is protein redistribution. So there is some promising research on this, and it looks at, again, protein is very important as we age, especially in nursing homes. So they're still getting 15 to 20% of their daily intake from protein, and there's a window for protein intake. We don't want them to have less than 1.1. Research shows us that that's not enough protein for these patients. And we don't want it more than 1.6 grams because that definitely is too much protein for the interaction of levodopa. So we want them in this fine window of 1.1 to 1.5 grams per kilogram. At breakfast, we make it carb heavy. We give them cereal loaded with fiber. We give them fruit loaded with fiber and water. At lunch, we still have it pretty carb heavy, and then we load them with protein before they go to bed. When they're not as worried about the interaction, they had a more successful time during the day. If they need or are having challenges getting enough calories in, a renal diet has been useful for this, and utilizing renal supplements, which are typically low in protein, if they're a renal chronic kidney disease, not on dialysis. So we're talking pre-dialysis, pre-end stage. So renal supplements that are low in protein but high in calories still. Okay, so now let's switch gears. We've level set. We know about medication and we know about the different symptoms of motor symptoms and non-motor symptoms. Let's talk about those nutritional concerns a little deeper. So 50 to 60% of people living with Parkinson's disease may have constipation. And I normally would start at the mouth and work my way down the GI tract to the bottom, but today, because constipation is such a challenging issue for our patients, I'm starting down at the bottom and we're gonna work our way back up to the mouth. This is why she had me come after lunch. Nobody wants to talk about what comes out before they go to eat. When I was training to become a dietitian, I got back into the room during my internship and I said, I did not realize I was gonna have to talk about poop so much as a dietitian, but I guess what goes in must come out, and an indicator of your health is your stools and how you're passing them. So the true definition of constipation is passing fewer than 3 stools a week. And you might think about this, is this me? Did I, a checklist? Okay, I'm clear, I don't have constipation. Passing fewer than 3 stools a week, having lumpy or hard stools, straining to have bowel movements, or maybe even feeling like there's blockage or it's not ever coming out, maybe even manual manipulation or having to massage your abdomen or something to try to get it out. Well, in Parkinson's disease, it could just be the disease state, right? There's slow intestinal transit or outlet obstruction because the muscles aren't working, they're not responding to the dopamine. A lot of Parkinson's patients are on pain medications, and we know pain medications can exacerbate constipation. Lack of water. So if you couldn't get up to go to the bathroom, right, because the brain is telling the body to move, but oftentimes in Parkinson's disease, it doesn't want to listen, I would probably stop drinking as much water. Well, not drinking enough water can exacerbate constipation, and it can exacerbate incontinence, which constipation can exacerbate incontinence, and oh my goodness, we got a real problem here. Compacted stool can also lead to incontinence, or that urgency and frequency to go to the bathroom. So lack of water, it's really not working. Now this patient's also not exercising, they're afraid to move, or they're not moving like they're supposed to because their dopamine's not working, the levodopa's not working, or they're not having enough fiber. In fact, in studies, against healthy controls, Parkinson's patients were found to have, a third of the patients were found to have not enough fiber and not enough water and not enough protein. These are some of the options for laxatives. Miralax has been studied specifically in Parkinson's patients and found to be effective, so it is appropriate to use in Parkinson's patients. Some of these are stool softeners, some of them are oral osmotics. They're up here in your book. I'm not going to deep dive into it too much. But think about the lifestyle of this. Think about you're constipated, you got incontinence issues, so you take a Miralax, and now you have diarrhea. And then the cycle goes on. Instead of trying to solve some of these problems by adjusting diet and adjusting our lifestyle, we try to Band-Aid it like we often do. So let's talk about some of the dietary treatment options. Lactobacillus probiotics. So there was a study looking at Parkinson's patients, and they had a fermented drink that included lactobacillus. So imagine like a yogurt drink, like a kefir. In that study, it was found that lactobacillus did help alleviate constipation in patients with Parkinson's disease. So that might be an option, or a smoothie drink that includes yogurt. Drinking more water and high fiber foods, both soluble and insoluble, and I'm going to deep dive into these further. Increasing fiber, so including bran. I have been doing presentations for some of the Parkinson's support groups, and I brought bran muffins into the last one, and I had some for my family, and man, do they work. Consuming shredded wheat cereals. So there's two different types of fiber. We have our insoluble fiber, and we have our soluble fiber. Insoluble fiber is the stuff that it's like the construction truck. Push it out, let's push it out. Soluble fiber is the type of fiber that creates a gummy, viscous water. It pulls water in, and that's your oats. And it's going to pull it in, create a viscous, so it's soft and full of water. You have to increase both. We need both kinds, especially in this disease state. So eating your fruits and vegetables, if you have the skin on, that's going to give you some insoluble fiber, as well as the soluble fiber. Prunes or prune juice daily is a great solution. Incorporating beans into the diet. I know they come with, some flatulence going on there, but it's okay. And then I have a recipe for a bowel regularity recipe. It's not that palatable. It's got oat bran, applesauce, and prune juice. But maybe you could incorporate it into oatmeal, or it's 2 tablespoons a day. Now, with any type of fiber increase, it is very important to increase water. If you don't increase water, but you increase your fiber is pulling water. So what happens is people don't drink a glass of 8 ounces water when they're consuming these things, and then they get gassy and cramps and then bloated, because the fiber is pulling from the intestines trying to find that water, pulling from the other organs to get that water in with that bulk. So it's very, very important to increase water. Some of the best practices could be having a fruit-infused water dispenser. When you go to a fancy hotel and they've got the cucumber water with mint have some of that. I mean, it always entices me to drink more water when I walk into a hotel with that stuff. Make sure the residents have a cup of water with a lid. So if they're getting dyskinetic or having tremors, that water is going to go everywhere, and it's going to make it really hard for them to consume it if they don't have the lid on. Vitamin waters. So juices, vitamin waters, things that taste good. I know I get sick of water sometimes, so I want maybe a green tea, something with mint. And increasing fruit consumption, because fruit is going to carry water with it. It's a snack food. They can pick it up. They don't have to worry about utensils, and it gives extra fiber. But with all that extra water, they might be worried about going to the bathroom. So there are solutions for that too. There are absorbent products, anticholinergic medications could help with that, and external internal drainage devices. Patients also are more likely to get a urinary tract infection if they're not drinking enough water. And so just so many reasons why fiber, water, exercise. Okay, we're going to talk about some of the different symptoms, motor symptoms, and some of the modifications that come along with that. So if somebody is bradykinetic, they might take more than 30 minutes to complete their meal in the dining hall. So for someone like that, that's really slow or having challenging getting through their whole meal in a during dining period, orders for snacks can be written. And it's important to give them that opportunity to have more snacks throughout the day. Meals can also be challenging to consume, so considering oral supplements that are liquid can be helpful, and writing those so that they come in between the meals is really useful. So a high protein, high calorie if they're having a lot of emaciation, or low protein, high calorie supplement to be ordered. With bradykinesia, you see how slow they're moving. Parkinson's also affects autonomic systems, or I like to say automatic systems, so you're not thinking about your GI tract pushing food through. Gastroparesis is one of those things. We don't think about our food going through the system. So we have a system called peristalsis. It contracts and relaxes. Those are the muscles in our body to help push it from the stomach, through the small intestine, through the colon, out the rectum. In gastroparesis, it's moving slower. So you can recognize this in your patients if a patient reports feeling full really quickly. Like, I'm just full. I can't eat any more on my plate. Or if they're vomiting whole or undigested foods. And I'm going to take a note here. You guys are the eyes and ears. Dietitians have really high ratios. They're not able to see the patients on the regular, unfortunately, and they aren't always able to get into the dining halls. So if you see these things, communication is the most important part of this. Reporting it, make sure that information gets over to the dietitian at the nursing home or whatever facility you're at. So this is the slowness of the emptying of the stomach, and it could lead to small intestinal bacterial overgrowth. So when the colon is backed up and it starts going into the small intestine and food is just sitting there, you might have too much bacteria and not a good kind of bacteria growing in there. I'm going to talk more about small intestinal bacterial overgrowth in a second. Now with bradykinesia or gastroparesis, it can be treated with prokinetic agents, but some of those might be contraindicated in Parkinson's disease. So it's important that that is noted and that we're not prescribing ones that are contraindicated. And another option is consuming smaller, more frequent meals. That's where the snack options and writing in snack orders could be very helpful so that they're given the opportunity more frequently throughout the day to try to get their food in. So SIBO, that's excessive bacteria, as I mentioned, in the small intestine. So we don't want bacteria. We don't want food just sitting in our small intestine. It's going to ferment, and not in a good way. So it's diagnosed by a breath test, so it's really easy to diagnose it. Symptoms can include diarrhea and bloating, abdominal distension, unintentional weight loss, malabsorption. I mean, these are things we're already worried about in this population. Now, you can treat it with antibiotics. There's a 43% relapse rate with this on patients that are treated with antibiotics, so they're very likely to have it happen again. So trying to incorporate other lifestyle things to try to improve intestinal transit can be useful. They may need vitamin replacement that is either on the doctor or the dietitian to try to make sure to address. And probiotics not only can also help constipation, but they can also help this condition. So that might be something else to consider. Either writing a prescription for, and make sure it's a lactobacillus probiotic. Drooling. So again, we're working our way up the GI tract. Now we're in the mouth. So there's lots of reasons why Parkinson's patients might drool more. And I'm bringing up, and it's common in patients. It causes psychosocial issues, and it's a risk, and it could cause aspiration and chest infection. So we want to make sure to address it if we can. Botox can help treat it. And I'm bringing it up because if you see drooling, they looked at drooling and its correlation to dysphagia. And dysphagia is the difficulty in swallowing. And so if drooling was present, the patient had dysphagia. And the more severe the drooling was, the more severe the dysphagia was. So if you're seeing it, it's important that the speech pathologist, then a note goes to the dietitian or a speech and language pathologist so they can be evaluated on a swallow test, and then they can have a modified diet. Oftentimes patients will cough or choke just on swallowing water, because the thinner the liquid, the more likely the aspiration risk. Patients can also be silent aspirators, so they're not coughing at all, it's not going down fast enough. And it could be, they could have bradykinesia and not able to push it down fast enough. Oops, sorry. So lots of concerns with that. Just make sure it gets addressed because it is a concern and a risk for other conditions. Okay, all that involuntary movement, shaking and dyskinesia. Patients, if you're moving all the time, you're using calories. Calories are energy. And so they're gonna need more calories if they're moving all the time. But the problem is they're moving all the time, they're having a hard time getting the food into their mouth. So packing it in with the fat. So fat, it has more calories per gram than carbohydrates or protein. So olive oil, avocados, canola oil, making sure their food has extra fat, makes it easier. Nuts and seeds can be choking risks, so maybe making it a nut butter and grinding it up, having things like smoothies to use that. Seeds like chia seeds, hemp seeds, or flax seeds, these are uber small seeds, so these aren't swallowing problems. These are really useful. They're fatty acids, omega-3 fatty acids. They have oftentimes extra fiber, and they have been found to be neuroprotective in other neurological diseases, not specific to Parkinson's disease. But my take on these superfoods, the chia seeds, hemp seeds, and flax seeds, are sprinkle them in. In my household, if you have trouble going to the bathroom, we start using flaxseed, and you will be fine. So it works really well. It can also have a possible depression benefit. Make sure to put oils and butters on their vegetables so that it tastes good. They want to eat more of it, get that extra fiber, and it's going to give them extra calories. And then consuming liquid calories like juices, smoothies, or shakes. If the patient is really rigid, and you might not be able to see this, but they might have trouble, and if they're really bradykinetic, you might have trouble swallowing. We're really talking about a lot of the swallowing, but avoiding choking hazards. So popcorn is a choking hazard. Whole nuts and seeds, dried chips, tortilla chips, potato chips, and dry foods. A solution would be then to choose soft foods, so steam the vegetables so there's extra moisture added in, mash or puree the foods, and avoiding sticky foods like taffies and peanut butter or caramels. So all these symptoms patients have, bradykinesia, tremor, rigidity, can cause a lot of challenging issues to get through a mealtime, and you can understand why patients might be getting malnourished. So some solutions, finger foods. So not relying on the utensils, making sure to cut their food up. So dietitians can write these orders in, but if they're not there to see it, or if you're not telling them that they can do this, they might not think to write these orders in. So they can write an order in for finger foods. They can write an order for it to be soft. They can have tough food. You avoid tough foods like pizza. It's hard to tear off. Have it pre-cut before it comes out to the patients. Allow snacks throughout the day, especially fruit and vegetables, and encourage protein shakes. And maybe encouraging the patient to eat more. Encourage the patient to have a snack. If they have postural instability, they might have lack of movement, or they might have that autonomic or orthostatic hypotension, right? They get up and they get dizzy, so they're fearful of getting up. Well, that inactivity exacerbates that constipation and may lead to dehydration. Small meals and caffeine can help, and encourage, if there's anything we've found in evidence and in the research, is that movement and exercise makes a difference in this population, whether for depression, mood, quality of life. So encourage them to go to therapy or exercise. So a few issues that might affect diet. 50% of patients with Parkinson's disease may have depression. And sometimes it's hard to know whether they have it because Parkinson's disease has that facial masking. So you can't tell by looking at them. Someone with facial masking might be perfectly fine, and you might assume that they might have depression. Or somebody that doesn't have it, you might assume not. So you can't really look at someone and say, oh, you're probably depressed. So it's important, though, that they understand that there is treatment if they're depressed, to talk to the doctor. There are antidepressants that have been studied in this population, and they're adjunctant to their Parkinson's medications, and they do work. And then omega-3 supplements might be helpful. It has been studied and shown to be improving their depression. And some of the side effects of dopaminergic medications is that impulse, right? That mood, that anticipatory. So if they're on a dopaminergic agent, dopamine agonist, or even after deep brain stimulation surgery or a amantadine treatment, they might have impulse control disorder. And one of the impulses they might have to overeat. So, it can manifest itself in many different ways. They might want to gamble a lot, they might want to do all sorts of things, or they might want to just eat a lot. If you notice this, make sure to bring it up because the medications can be adjusted. So in summary, it's so important that we get the timing of this medication right in regard to their mealtime so that we can maximize that on time and help improve their quality of life or their on time and your job. If they're on, it's gonna make things easier for you guys. And first, optimizing that, making sure it's all right, then if they're on, they'll have a more successful time trying to eat. Communication is the key. I mean, that's in all things, right? So making sure to identify malnutrition and address it in a timely manner. I mean, there's gonna be triggers to get the dietitian to review the patients, 5% weight loss in a month or 10% over 6 months, but 10% over 6 months, I mean, how much bad can happen over 6 months and that patient's already wasting so much? If you see the signs and symptoms, if you're noticing it ahead of time. Constipation is common, but there are interventions, and with your encouragement and teamwork, we can get there, along with making sure they have enough hydration so they don't have GI discomfort if they are increasing their fiber and such. And if they're depressed, they need to be addressed through improved nutritional status. So we're gonna take questions at the end because Michael is up next.
Well, good afternoon, everybody. I'm Michael Courtney, as the doctor told. I'm the corporate dietitian with CIENA Healthcare. We have 39 homes in Michigan. We do short-term skilled care rehab and long-term care as well. So when I was asked to do this presentation, Sara basically covered all of the medical nutritional therapy. I was asked to kind of focus on what we do when we receive a resident with Parkinson's disease into our facility or our type of facility, and just kind of how we monitor the progression and what we try to do. So first thing we do, we try to see all of our residents within 24 hours. So the biggest thing, we want them to eat. We want them to tolerate what they're getting. We want them to see if there's any allergies and tolerances. So the first thing we do is we have to see them. What do you like? What do you don't like? Are you on the proper diet? Do you need to see a speech therapist? We discuss their diet history. If they're used to eating 6 meals a day, if they're used to, maybe they're a late morning person, they might want to eat late breakfast. We try to get an idea of where, we have our normal 3 meals, but we always have the opportunities to change them as needed. Of course, we also want to see what their ability to feed themselves are. Some residents might come in being able to require just setup. Then we have some residents that may require 100% assistance or total assistance. So we like to get that information as soon as we come in so we can make sure we're providing them the right food, the food they like, and providing them the level of assistance that they're going to require. What the RD does when they come in, after we get all of our information, we do nutritional risk assessments. What we do is we obviously look at all the data on the resident, figure out what their calorie needs are. Obviously, we can't just say every resident's calorie needs are 2,000 calories. So we focus in on what their protein needs are, fluid needs, and through this, we look at their medication reviews, labs, obviously if they're having other secondary medical conditions, if they're having renal failure in addition to having Parkinson's, obviously we gotta monitor their protein to a certain extent because of the renal disease, but we also want them to get enough protein where we're not gonna have any malnourishment or any skin integrity issues. So we kind of take that all into account. And then we make referrals in our long-term care facility to many disciplines because obviously a resident coming in with Parkinson's is gonna require different therapies and different consults. So who do we make referrals to? Obviously, as Sara kind of talked about earlier, speech-language pathology to determine proper diet consistency. Occupational therapists, we have occupational therapists in-house to assess their ADL abilities as far as being able to pick up the foods, being able to feed themselves. That's when we also get into looking at, do we need finger foods? Do we need specialized utensils and stuff like that? We're going to get a little more into that later on. We do have restorative nursing programs, so if they're not skilled therapy through Medicare, we have restorative therapy. This is kind of like a functional therapy, which kind of assist with feeding and kind of their ADLs and keeping them to the best of their ability that they can. We have dental consults. Of course, we want to make sure that their dentition is proper, that they already might have trouble eating and have difficulty, so we want to make sure that their dentition's correct, if they need dentures, if they're ill-fitting, those types of things. So, and how do we monitor these residents once they're in our facility? I'm not sure if anyone here has been in long-term facilities or has worked in long-term care, but there's meetings, and more meetings. I've been in the industry for 20 years, in long-term care, so I started when I was 5, as you can see. But that's the one thing that if nothing at all, we have meetings. We meet every single morning, discuss our residents. What we look at is, specific to nutrition, is we looked with our electronic medical record, we can pull to see what residents ate less than 50% of their meals, what residents triggered for a significant weight loss. We can look to see if a resident did not have a bowel movement for 3 days, any new labs that came in the next day, and medication. So we review all those during our morning meeting, make sure that, if specific people need to be seen, then we do that, and we follow up at the end of the day with those particular things. We have resident at-risk meetings weekly, which we bring all of our residents that are considered to be nutritionally at risk, weight loss, if they can't feed themselves, if they're on mechanically altered diets, we tend to bring those in as well, make sure that they're consuming those correctly or sufficiently. And something that's kind of a little unique to long-term care is we use a lot of care planning. So we identify what the problem is. We just have goals, and then we have different approaches. So we review those every morning, make sure that the interventions are still appropriate. Other meetings we have with families, we have care conferences, because obviously it's important to get the families involved. So within the first 2 weeks of admission, once we kind of assess how the resident's doing, we get the family in, and the resident as well. The resident, if they're able to, comes into the meeting just to see how they're progressing towards their goals, if there's other things that the family thinks they should be doing or not be doing. So, and then the quarterly meetings we do as well. We have food committee meetings to make sure that the food's sufficient for all of our residents. We let them drive our menus as far as particular items they like, don't like. We have buildings in Detroit, we got buildings in Escanaba, so we can't really have one specific menu, so we kind of incorporate it based on the ethnicity. Okay, so what are the biggest challenges we have with our residents with Parkinson's disease? We're gonna go a little more in depth in these. As we discussed, dysphagia is probably number one, with inability to feed themselves being an issue. Some of these we talked already, what Sara kind of briefed over, but I'm gonna go a little more into it. Maintaining proper hydration, their meal times, locations, and as we discussed a little bit about unintended weight loss and some residents that actually gain weight. So dysphagia. Most of our buildings all of our buildings have a speech therapist. Some are full-time, some are part-time, depending on how big the building is. Obviously, they're gonna come in, do a bedside swallow eval, determine what type of mechanically altered diet they need to be on. Also, if there's some signs and symptoms of silent aspiration, we can do modified barium swallow studies as well. They go over different swallowing techniques, if it needs to be like a tuck swallow, look for signs of pocketing and all those types of things. So majority of our residents with Parkinson's will get an SLP consult regardless of what stage they're at. And then, has anyone heard of the new dysphagia diet that's come out? It's called IDDSI. It's kind of a new, instead of just having your basic pureed food, your mechanical soft food, and your regular food, it's kind of, they're adding more elements into it, so you're not just getting that. I'm actually a Facebook member of a group. It's called Itsy Witsy. It's kind of weird, but they kind of get a lot of good information on that. So, but they have, instead of going from like a mechanical soft to a puree, there's something called moist and minced. So it's kind of a combination of those two with a residents on puree that can kind of upgrade, but not all the way to mechanical soft. We have kind of a mixture. So we're working on that. Our company is one of the first to, hospitals are working on it, but our long-term care skilled facility is working with U of M Hospital, Ohio State University, working with them on this new program and rollout. So we're gonna be trialing it in a few of our buildings starting July 1st. And they also have a step between regular diets and mechanical soft, which is kind of like chopped foods. So it's a great thing that they're doing instead of being limited to specific diets. Inability to feed self. Of course, we always want to promote as much independence as possible. That's always our goal. So we don't want to just go in there and start feeding the resident when the resident could at least do some things for themselves. Nursing staff has to be properly trained to assist with feeding. And our facility staff is also able to, if they get competency trained by speech or other nursing, they can actually feed residents as well. So it's not just like we're relying on nursing aides, or maybe the housekeeping supervisor or the maintenance director, as long as they're properly trained on swallowing techniques and signs and symptoms of if they're aspirating, stuff like that. So in our industry, we kind of have an all hands on deck. Of course, use of adaptive equipment and utensils and aid in feeding self. There's something called careful hand feeding I threw in here of something I never really heard the terminology of, but it's something we do. It's just giving someone small amounts of food and drink when a resident can no longer feed themselves. That's kind of what we use it as terminology. It just works well as long as the resident's comfortable with it. Obviously, we're never force-feeding residents. And back to our adaptive equipment. I kind of compiled a list of things that we use to aid in independence in feeding. We use scoop plates, so when they're kind of scooping the food, they have kind of a lip there, so they can kind of keep it on their fork or their spoon or spoon better. Some angled utensils are good if residents have some rigidity and stuff like that. So we can kind of use their utensils. Weighted silverware is sometimes easier than trying to hold like a tiny, the base of it. We have heavier silverware. Nosy cups, which has like a cutout on the cup, so you don't have to lift your head all the way back. You kind of just toss it back, and it goes between your nose, so you're not worrying about spills and stuff like that. Spill-proof cups, I think we discussed earlier. Two-handle cups, we have kind of like if they can't really grasp a cup by themselves, they kind of could hold on to a dual one, and it's easier to feed themselves or give themselves drinks. And a lot of our Parkinson's residents, we make sure we have some sort of DISM or some sort of like resistance underneath their plate, so their plate doesn't slide around. It's like a rubbery kind of traction. So if they're moving their hands around, this plate's not going all the way around. It kind of stays by itself. Maintaining proper hydration. Sara pretty much covered a good portion of it. But what we do is we calculate their needs for fluid upon admission. We calculate how much they're getting with their meals and how much. The key is that they have to get those between meals hydration. So I know that's one of my biggest struggles in some of the buildings sometimes is making sure that they're doing water pass correctly on time, so they're getting their water and fluids with meals in addition to between meals. So and as Sara alluded to, residents that are on thickened liquids because of dysphagia, they are our highest risk for dehydration is because they're not drinking as much. Obviously, it doesn't taste as good. They don't want to drink as much. It's just those are residents that we focus on. When we look at meal times and locations, another one that Sara discussed, the Levodopa, given strategically around times. I always get asked the question, should a resident with Parkinson's eat in the dining room or in their room? And the answer is yes. It's subjective to each particular resident. Some residents do better in a quiet setting, so they might want to keep them, they might do better eating in their room. Some residents do better in a social setting, so we take them out to the dining room. We don't want to take them out where it's too much activity going on, but just having people around, some socialization is good. So it's there's really no answer. It's specific to that particular resident and how they're doing. It might vary on a day-to-day basis too. They might have good days, bad days. Like Sara said, sometimes they're on or off. Just depends on the medications and stuff like that. So another thing we make sure we do with our residents with Parkinson's is we make sure we use heated plates and pellets because they're going to take a longer time to eat. So we want to make sure their food's staying hotter longer. Just because, it might take someone 10 minutes to eat, but if it takes someone with, who's kind of struggling along, it might take them a half hour, 40 minutes. So we obviously want the food to be palatable. We want the food to be hot like it was when they got it. So we want to make sure that they have all the proper heating elements to keep their food hot. Between meal snacks is very important, especially for people that don't eat more than 75% of their meals. We do snacks all day long. A lot of our buildings have kind of like an order, like a after hours, like all day type menu. So if they want something in between meals, it's not just, here's your graham crackers, here's your Lorna Doones type thing that you might see, old school nursing home type stuff. We actually have, making sandwiches for them, making salads, making those types of things. So we kind of have a nice between meal menu. And then other thing about meal times and seating is making sure residents are sitting upright during meals to avoid aspiration, and that they're staying up for 30 minutes after their meals. I know we kind of talked about the medication portion. A lot of research also shows that residents tend to be the most awake at lunchtime, so we try to give them as many calories as we can at the lunchtime, because they're more awake as opposed to breakfast and dinner. So to optimize as many calories as they need to get, giving them the biggest meal at lunchtime is ideal, and we do that in the majority of our buildings. Cutting food into small pieces, finger foods like we talked about is something we utilize. And then another thing we alluded to, Parkinson's disease definitely deteriorates your sense of smell, sense of taste. So we actually have a corporate chef that works for our company, and he works on certain foods that are like slightly over-seasoned, certain things that are making sure they're not bland, because obviously if someone with the Parkinson's disease is gonna, kind of taste that blandness already. So we, I don't want to say we over-season their food, but we have certain things that we give them that kind of kick out the taste buds a little more, so it's more palatable to them. It's not just like they're kind of eating something that's bland or blah. One of the biggest things in our industry is unintended weight loss. People with Parkinson's are 4 times as likely to lose weight than people of the same age that don't have Parkinson's. Common reasons, we kind of went over a few of these already, but decreased PO intake is obviously number one. There's a lot of reasons for it. Requiring a mechanically altered diet is obviously puts someone at risk for decreased intake just because it's not the normal food they're used to eating. So some people struggle with that. Inability to feed themselves obviously factors into how much they can consume. The inability to verbalize hunger, so maybe they're actually hungry between meals, we're just giving them something small, but they really want a bigger meal, but they're not able to verbalize it, and they're losing weight. And then some of the side effects of this stuff, the medications taken cause unintended weight loss as well. A few other things we talked about, dyskinesia, tremors. Obviously, the more the body's moving, the more it's burning calories, like we discussed, so that's at risk for weight loss. We discussed the depression aspect already. Obviously, with weight loss comes other factors that can happen, infections. One thing that, if they're not moving around well, not eating well, pressure ulcers is always a concern in the long-term care facility. Making sure that we're giving them enough protein to prevent that. And they're also at high risk of pressure ulcers due to the redistribution of body fat and restriction of movement. Interventions that we use in our industry, I always say food first. Everyone's always quick to give a Ensure or Boost or something like that. I always instruct my dietitians that, making sure we're utilizing food first. We're making sure they're getting the preferences that they want, making sure that they're getting the assistance they want. One thing, the first intervention we always use is an enhanced or fortified foods, which is basically the same type of foods that everyone's getting, but it's like in the mashed potatoes, it has extra butter. We use evaporated milk. We have soups that are fortified, where we add in certain high-calorie items. We actually have a whole list that our corporate chef worked on. We probably have 20 or 30 items that we do that are enhanced. This is basically almost doubling the amount of calories. So that's what we go with first, making sure they're eating, making sure that they're getting meals between snacks. Are we providing the least restrictive diet as possible? Sometimes we have someone on a therapeutic diet, and they're not eating very good. They're on, restrictions from all different, carb control diets or renal diets. Do they really need to be on them? Do we need to, we need to make sure they're getting the calories in. So we want to be as least restrictive as possible. And then at the end, if those interventions aren't working, then, we do have supplements available. One of my biggest pet peeves is when they put the supplement right on a tray, their lunch tray, and then they drink that thing, and then don't even touch the tray. So if we give supplements, ideally should be giving it between meals so they can consume their meal. Of course, if that's what they want, if they prefer to have it with the meal, of course, we'll do that. But just to optimize their amount of PO intake, we do it between meals. And just a little bit about unintended weight gain. We kind of went over this already. Some of the reasons are just being less active. They're consuming the same amount of food as they did prior to, so their appetite's good, but they're less active. So obviously, they're not burning as many calories, but they're consuming the same. So, and then some side effects of therapies like the deep brain stimulation of dopamine, which you kind of alluded to with the compulsory behavior, which can lead to compulsive eating as well. And lastly, there's just a couple vitamins and supplements that have been looked at. There's really not a lot of vitamins and supplements that we give residents with Parkinson's. We do want to make sure they're getting enough calcium and vitamin D to prevent osteoporosis. And there's been studies that shown that making sure that they're getting proper antioxidants to stop the effects of the free radicals that could be happening, making sure that they can stave off infections and stuff like that. So, and back to questions for both of us.
Okay, does anybody have any? Okay.
This is a question for Sara. You mentioned drooling, but I've seen quite the opposite with a really, really dry mouth, probably from side effects of meds. Is there any tricks to that?
Well, actually, Michael, with an intervention of dry mouth, chewing gum, and there's different stimulants to saliva. There's Oragel.
Yep, we do Oragel. We do they have mouth swabs that can assist the residents with kind of just keeping the oral mucosa moist. Mm-hmm. But you're right, it's kind of a double-edged sword sometimes. But there's
Other question? Over here.
What's the biggest challenge on the weekends? Are you guys able to actually start the admission process, like if they come a late Friday, or is it just wait till Monday? Because I would usually work off shifts, and I see that's a big problem.
Well, in our facilities, we have weekend staff that in the kitchen that's required to go visit the resident. We're not going to get a full assessment. Most likely not going to get the full assessment done. We're going to get those initial food preferences. We're going to get those initial food intolerances, diet histories. We actually have a form that we give our, whoever's in charge on that weekend, the cook, if they get a new admission, then they're in charge of taking this. It's a form that they, it's not subjective. They just go in, ask them these questions, and then they have access to the tray card system where they can put in the foods that they like, dislike, and we can make sure we're taking care of that right away until Monday, where we can get, more of a full assessment, referrals, and consults and stuff like that done. But you're right, that is definitely a challenge.
Hi. Knowing, you have the nutritional, but how often do you weigh your patients or your residents? Because my mom was in a nursing home, and she had Alzheimer's, though, and they did weekly weights, but it was like, in Fort Knox, trying to get the weight out of the resident, for them, because I was concerned about her weight loss, and if she got below 100 pounds, I was really concerned for her health risk. Being a nurse in that, but I was wondering how your facilities do it.
Our standard is within that 24-hour period of admission, we weigh the resident to kind of get an initial baseline. 48 hours later, we weigh them again just to kind of make sure the baseline's kind of where we go, and then we do weekly weights for 4 weeks. And what we do is we have a certain day of the week where this is the weekly weights, maybe Tuesday. Every building kind of does it a little different, but they do it. So every Tuesday you have to have a weight done, and if your weight's 5 pounds different from your previous weight, we have to do a re-weight right then just to validate that the weight is either a weight gain or weight loss if there's that big of a variance. But we do 4 weeks of weekly weights, and if they continue to have insidious weight loss or gain, we just continue them on. We have some residents, if they have maybe a CHF diagnosis along with the Parkinson's and other stuff, we might weigh them daily just because they might have fluid imbalances. So, but minimum at a week. Thanks.
So my question is about somebody who's in the community, so maybe Sara, I don't know if you can answer this. You went over in the nursing home, the main meal is the lunch meal, the biggest meal of the day. For somebody who's in the community, your breakdown for breakfast, lunch, and dinner, and you had talked about dinner being the heaviest, protein meal.
Protein meal.
Protein.
So
Yeah.
does that still kind of translate where maybe somebody in the community, lunch should be the biggest quantity of meal, but dinner should still be protein heavy?
Well, what we do, as far as calorie heavy, we do it as the lunch meal.
I'm talking about somebody in the community, somebody who's living at home.
True. Well, I mean, what I was referring to is they're typically the most awake at that particular time. So I guess it kind of can vary. You know, so maybe someone with Parkinson's is more awake at night, but the protein distribution is definitely, like Sara said, needs to be higher.
But their biggest meal should be when they're most alert.
Correct. Yes,
And
that's
my
fine.
second question is about the supplements. You mentioned omega-3s for depression, and then your slide briefly said something about calcium, vitamin D, and antioxidants. Are there any other specific, like vitamin deficiency or mineral deficiency in somebody with Parkinson's, or does that not really vary?
There's definitely no consistent. There's no consistent. I mean, every resident, like if you have an actual lab value showing like low magnesium or something like that potentially, but there's, from what I've been reading, there's really nothing consistent as far as, you know, that this particular supplement should be given or vitamin should be given or deficient in. It's a lot of the, like I said, the vitamin D and calcium, and then just making sure we're avoiding infections, so making sure antioxidants.
If they're chronically using laxatives, they might have mineral electrolyte imbalances. So I think I listed, but I'll make sure to list, if I didn't list in the book, some of the different vitamins and minerals that can be affected by that. But definitely the calcium and vitamin D for the osteoporosis risk has been seen in the literature, and just a general multivitamin. And then, like I said, the literature shows a lot of promise for the probiotics. So a lactobacillus-based probiotic, you could probably get it as a pill.
Any other? I guess not. Well, Sara, Michael, thank you so much for sharing your expertise. Very grateful.